I would like to welcome our speaker tonight, our colleague, Dr. Hareesh Singam, who is going to be talking about adverse effects associated with cancer immunotherapies. So, Dr. Singham, the floor is yours.
Thank you, Dr. Ayler. So today I'm going to talk about adverse effects associated with cancer immunotherapies. This talk is broken up into two broad categories, two sections of this presentation. The first half of the presentation, we're going to talk about inflammatory syndromes associated with immune checkpoint inhibitors. And the second half of the talk, we're going to talk about inflammatory syndromes associated with CAR-T cell therapy. This talk is based on an article by Dr. Fishman, published in CID, titled Inflammatory and Infectious Syndromes Associated with Cancer Immunotherapies. This was published in 2019. It's a great paper on this topic. So the first topic we're going to talk about, or the first category we're going to talk about, are immune checkpoint inhibitors. Immune modulation or immunotherapy is the cornerstone for organ transplantation and cancer therapy. Cytokine therapies have dramatically altered by immune checkpoint inhibitors that target surface immune checkpoint receptors on cells. The two broad categories I want to talk about today, which are the CTLA-4 and the PD-1 and the PD-1L. The CTLA-4 stands for cytotoxic T lymphocyte-associated protein 4, and the PD-1, the PD basically stands for programmed cell death receptor, and the L stands for ligand. So these are two things we talk about. We usually rotate at Moffitt as a part of our infectious disease fellowship, and at Moffitt and in some other places such as the VA and at TGH, we've seen these checkpoint inhibitors. An example of the cytotoxic T lymphocyte protein 4 inhibitors are the example of this is ipilimumab and tremelimumab, and these are used for melanoma. For the PD-1 inhibitors, the two drugs are pembrolizumab and nivolumab, and there are new ones coming up all the time, but these are some of the examples that we see more often. And these pembrolizumab and nivolumab are used for melanoma, renal cell cancer, and metastatic non-small cell lung cancer, and multiple others. Then you have the PD-1 ligands, and these are examples of these are the atezolizumab, avelumab, and durvalumab, and these are usually used for urethral cancers. All right, so let's talk about the CTLA-4 checkpoint inhibitors. So this is one category that we want to talk about, and the CTLA-4 are usually or immune checkpoint that are induced by the T cell at the time of the initial antigen binding. The level of CTLA-4 it depends on this TCR mediated signaling right here. So basically, if the CTLA-4 binds to the B7, the CD80 and 86 of the tumor cell, it inhibits the activation of the T cell. So if you block the CTLA-4 over here, and examples of these that do are ipilimumab and tremelimumab, sorry, my PowerPoint keeps on going randomly. If you block the CTLA-4 over there, it allows for unrestrained CD8 effector and cytotoxic T cell activation as well. So the next one we're going to talk about is the PD-1 checkpoint inhibitors. Pretty much the same idea over here as well. Use of the TCR binding over there, and that kind of activates the PD-1, and the PD-1 usually binds to the PD-1L. And if you block these, whether it's by pembrolizumab or nivolumab, it allows for the unrestrained CD8 effector or cytotoxic T cell activation. So in general, toxicities can be due to multiple reasons. One of the most common thing is that when you're killing cancer cells, this causes tumor lysis syndrome. And this can, happens in multiple chemotherapies, and this is one of them. When you kill cells, this release inflammatory cytokines, and this leads to fevers and can lead to bystander cell damage, where you kill cells nearby that you don't mean to. You could also inadvertently attack cells that in normal tissues that also express immune checkpoint receptors as well. And the example of this would be the thyroid and the pituitary that we're going to talk about in the next couple of slides. And obviously, these inhibitors that we saw in our clinical practice can also cause colitis, skin rashes, pneumonitis, and endocrine dysfunction. And a lot of these syndromes can mimic infections. So it's always important to rule out infections in these situations. So, so in general, in the broad strokes, when you have immune checkpoint inhibitors, the toxicities are usually within weeks of initial treatment. If you have toxicities after 3 to 6 months, that's pretty unusual. You should look for other etiologies of whatever clinical syndrome you presented with. Adverse reactions with CTLA-4 therapies tend to be more severe than with PD-1 or PD-1L. And obviously, toxicity can vary by agent, dose, and the type of malignancy that you're trying to treat with it. If you're giving someone prolonged therapy, they're more likely to get side effects that are more rarer, such as pancreatitis, cardiomyopathy, uveitis, and whatnot. If you're not able to tolerate one agent in that class, doesn't mean that you cannot tolerate another agent in that class. So you could, so you might see your oncologist switch from, one agent to another agent, even though they have the same mechanism of action. When you combine CTLA-4 immune checkpoint inhibitor with a PD-1 immune checkpoint inhibitor, it increases the rate and severity of the toxicity that you're presented with. And one thing that's kind of interesting is that if you give influenza vaccine after these therapies, you may increase CNS toxicities. So let's talk about one of the more common skin toxicity with immune checkpoint inhibitors, which are skin toxicities. The skin rash is common in ICI therapy for melanoma and usually one of the first side effects that you see. It can present as erythematous or maculopapular rash and seen in extremities within 2 to 3 weeks after therapy. Some of the other things that skin presentations that could present itself are vitiligo, joint pruritus, sweet syndrome, dermatomyositis. You can also have, like with any drug, you have severe Stevens-Johnson syndrome, cause photosensitivity. So obviously this can mimic some infectious etiologies as well, like staphylococcal, streptococcal diseases in certain presentations. So you want to get blood cultures. You may want to do a skin biopsy to help you define these better. Okay, and this is a patient in this image, just a generalized rash from the patient with immune checkpoint inhibitors. Let's talk about endocrine toxicities. Sorry, I don't know why this is just going randomly, but let's talk about endocrine toxicities associated with immune checkpoint inhibitors. The most common occur within 6 to 12 weeks into therapy, and thyroid dysfunction is more common with PD-1 inhibitors. And usually you see hypothyroidism more than hyperthyroidism. And you see hypothyroidism because of the antithyroid antibodies that are produced from these inhibitors. Not produced from the inhibitors, but as a consequence of the inhibitor therapy. CTLA-4 blockade leads to more pituitary involvement and can occur up to 17% of patients. And the patients usually present with more like endocrine dysfunction, where they have vague symptoms such as fatigue, gonadal dysfunction, behavioral changes, temperature intolerance, generally in males. And patients can also have elevated intracranial pressure as well, and this can lead to diplopia and headaches. So to diagnose this, usually you go with an MRI and hormonal testing. You want to see how the patient's TSH levels, T4 levels, ACTH level, cortisol levels, and whatnot. In the image here, you can see destruction of the thyroid follicle on a patient with, I believe this patient was on ipilimumab, and this was on an H&E stain. So then let's talk about the gastrointestinal toxicities. Usually with PD-1 inhibitors, you're more likely to get mucositis and dry mouth. at usually 2 to 6 weeks. And with CTLA antagonists, you're more likely to get colitis. And colitis can be very severe, where people have profound diarrhea, which can be with some blood, abdominal pain. They could also have polyarthritis, nausea, fevers, and they could also end up having ulcers, fistulae, abscesses, and depends on. In some cases, it could be as severe as perforation as well, especially if they have tumor-lysis issues. And usually, histopathology usually shows neutrophilic infiltrates and apoptosis within the epithelial cells and within the crypts as well. As you can see in this pathology slide here on slide C. And the CT may demonstrate bowel wall edema, abscess, and perforations we talked about earlier. And in some cases, 10% of patients can usually experience hepatitis. And hepatitis is usually asymptomatic and is usually more common in people who receive combination therapy of PD-1 and CTLA-4 antagonists. And going back to this image over here, this patient in Japan was on Novolumab, and you can see the colitis on colonoscopy in pictures A and B. And in D, this is when he was off the agent for about 1 month, and they did a repeat colonoscopy, and you can see that the colitis has mostly resolved. So as with any gastrointestinal issues, you want to rule out C. diff, you want to rule out CMV, norovirus, and maybe get a GI PCR to look up to rule out other bacterial causes as well. So yeah. So next, let's talk about immune checkpoint inhibitors and their pulmonary toxicities. They usually mimic pneumonia and may be life-threatening. Pneumonitis usually occurs about 3 months, but there are some cases where you have hyperacute pneumonitis where it occurs within a week of therapy. The symptoms are usually dyspnea and cough, and some people may have radiological findings, but may be completely asymptomatic. 6% of patients who receive PD-1 and PD-1L antagonists develop pneumonitis, and this can be may progress as bad as ARDS, although this is kind of rare, but it's been known to happen. And I think we've seen a couple of cases of VA of this. Obviously, if you're on combination blockers of PD-1 and CTLA-4, you're more likely to have a higher risk of PCP, mycobacteria, and atypical infections. Again, with all of these immune checkpoint inhibitors, you want to rule out infectious causes and then blame it on the drug. So you want to do a BAL to look for infections or malignancy, the underlying malignancy that's contributing to it. And usually the BAL labs usually indicate lymphocytic predominance, especially if it's related to the checkpoint inhibitor. And the treatment for this is usually steroids. We won't get to that in the next couple of slides, but steroids is usually the treatment for a lot of these toxicities. So as you can see in this image, a patient comes in, he was on pembrolizumab, and you can see the X-ray and the CT. The CT kind of looks like COVID on the peripheral granular opacities on that. So next let's talk about nervous system toxicities. Most of these occur within the first initial 6 to 13 weeks. They affect both the central and peripheral nervous systems, and they could present as symmetric or asymmetric sensory or motor or autonomic defects. In some cases, you could have aseptic meningitis. However, with immune checkpoint inhibitors, generally you don't have any seizures. If you do see seizures, then you may want to rule out infectious etiologies, or if you see encephalitis as well, you want to rule out infectious etiologies, as it's usually not how these inhibitors present as. They also tend to have, they could also lead to myasthenia gravis, transient myelitis, Guillain-Barré syndrome as well. You want to help you diagnose this, you want to get an MRI. You also want to do CSF studies to look for infectious etiologies, and that could be a hindrance in most of these cases, as most of these people are profoundly pancytopenic and you may not be able to do a lumbar puncture. Next, let's talk about the musculoskeletal toxicities. Usually this can present as arthritis, myositis, polymyalgia-like syndrome, and they could also lead to autoimmune rheumatological disorders such as Sjögren's syndrome, rheumatoid arthritis, and some people can also have immune thrombocytopenia as well. In this image, you can see a patient on one of the checkpoint inhibitors, and you can see the necrotic skeletal muscle fibers, especially in E. Okay, so how do you manage all this? The challenge of this is to distinguish between infection and immune-related events, and this may not be easy to do sometimes. That's why a lot of times we just give empiric antibiotics as well, just to rule out infectious etiologies that could mimic this. ICI therapy at baseline is not known to increase your risk of infection, but your underlying malignancy and chemotherapy do increase your risk for infection. But the immune checkpoints and inhibitors themselves have not been shown to have increased risk for infection. Most non-endocrine toxicities are treated with systemic steroids. And usually you could give prednisone 1 to 2 milligrams per kilogram per day, or solumedrol or methylprednisone 125 milligrams per day. If you have colitis, you could consider budesonide. And remember that whenever you give steroid therapy, especially prolonged corticosteroid therapy, you want to give them prophylactically with PCP. Noting that the downside of giving steroids is that it can mask an infection that could come later, or symptoms of infection as well. And if they have persistent symptoms greater than a week, you could also consider adding TNF inhibitors as well. Remember, when you give TNF alpha inhibitors, you're likely to increase the risk of tuberculosis or presentation of fungi as well. So you want to screen them for TB, endemic fungi, and hepatitis B and C prior to starting these treatments. And usually immunosuppression is weaned after 4 to 6 weeks. Okay? So next, let's talk about CAR-T cell therapy and inflammatory syndromes and infections associated with this. So immune effector cells, such as T lymphocytes, are generally engineered with tumor antigens and are used in adaptive cell transfer. These are genetically modified into chimeric antigen receptor T cells, and they're used to infuse, engraft, and proliferate and kill tumor cells, provide long-term surveillance. Each therapy associated with is associated with adverse events that may mimic or worsen infectious syndromes, and so let's talk about these a little more, right? So basically, CAR-T cells, you obtain them from the patient. You genetically modify them and insert a gene for CAR. The CAR stands for chimeric antigen receptor, and the T cell now has expressed the receptor. You grow this in a petri dish, millions of them, and you infuse it back into the patient, where you hope that the CAR, the antigen, would bind to the specific cancer cell. So the whole point of the receptor is to specifically target a cancer cell. So let's talk about one example. Okay, so you have you want to develop CARs against CD19. So they bind to the CD19 on the tumor cell if the tumor cell is expressing CD19. So you want to bind to the tumor cell and activate the T cell to kill the tumor cell. So this is more targeted cancer therapy. So these are the available CAR-T cells. For anti-CD19, you have tisagenlecell. The brand name for this is Chimera, that we've seen in our BMT rotations, and this is used for ALL, NHL, diffuse large B-cell lymphoma, high-grade B-cell lymphoma. Then you have the another variant of this from, I guess, a competitor is axibitidine, and the brand name for this is Yescarta, and this is mainly used for more or less the same indication as Chimera. Okay, so in general, adverse events associated with CAR-T toxicities occur in recipients in addition to infections related to, sorry, keeps on going. Infections related to prior therapies. So, and these CAR-T cells can cause tumor lysis, and it depends where you are in the body. You could cause peritonitis if you, or it could cause pleuritis. It really depends where you are, where the cancer is, and specifically treating it. Sometimes people have multiple CAR-T therapies, and that puts them at a risk for anaphylaxis because they have multiple infusions. And two of the most common challenging toxicity with CAR-T therapy is cytokine release syndrome that we know well about, especially during our rotations, and CAR-T related encephalopathy syndrome that we see often as well. So let's talk about cytokine release syndrome. Timing of cytokine release syndrome typically coincides with the neutropenia nadir from the conditioning chemotherapy. Usually multiple organ systems are involved, and the rashes are usually not common in this situation. The patient usually has elevated, to diagnose it, it will help you know what the CRP levels are, because usually these are indirect measure of the interleukin IL-6 activity, which is noted in CRS. And usually you also see an increase in ferritin, which is a delayed marker that peaks about 24 to 48 hours after the peak of clinical syndrome. And one thing that's interesting is that most manufacturers have their own independent grading system to help you diagnose diagnosis and therapy. Let's talk about one of them. This is an example for Yescarta, axi-cell, CRS grading system. So grade 1 is basically not life-threatening. They just have mild headaches, maybe malaise, fevers. Grade 2 is when they require a little more oxygen, basically, and maybe low-dose pressors. Grade 3 is when they require higher amounts of oxygen, such as high flow, require multiple pressors. They have worsening condition that can lead to grade 4, which is more likely when they need ventilator support or dialysis, renal replacement therapy. And the treatment is dependent on the grade. Basically, if you're grade 1, you just kind of watch it, supportive care. Grade 2 requires Tocilizumab. Grade 3 requires prednisone. And grade 4 requires usually higher doses of prednisone. So, and as you give more prednisone, the CAR-T therapy becomes less, there's less efficacy with that. So, let's talk about CAR-T related encephalopathy syndrome. This usually presents within 8 weeks of treatment. The patient may have mild symptoms, just altered cognition. It may progress to seizures and focal neurological deficits, and the patient may even be obtunded. And the more severe signs are usually due to more edema. As you can see in this image, image A is at baseline, patient's MRI, and image B is patient with edema, especially with the astroskis, where you can see the edema. Usually when your edema is bad enough, it could cause a brain herniation. People have known to die from this. But most of the time, people just have waxing and waning of neurological symptoms, and it's usually transient. And remember, more severe CRES is observed in those with higher grades of CRS syndrome. And they may coexist as well, especially within the first 3 to 5 days of therapy. So, later phase of CRES therapy, usually the treatment that may help is steroids. One way you can help you diagnose this is that if you can get an LP. Again, most of these people are pretty pancytopenic, and the platelet count may not enable you to do that. But if you're able to, you may be able to see CAR-T cells within the CSF. And then you can also get an EEG, which shows generalized slowing and epileptic discharge without frank seizure activity. And you also want to get your MEP panel, so you want to rule out infectious causes as well. So, sorry, I don't know why this keeps on going away on its own. So, sorry, I don't know what's going on. Pause it. Okay, so we're going to talk about HLH and CAR-T related HLH and macrophage activation syndrome. So HLH stands for hemophagocytic lyphohistiocytosis, and is basically driven by hyperactivation of the macrophages and lymphocytes into the tissue infiltration and pro-inflammatory cytokine production, resulting in multi-organ dysfunction. The features of CRS overlap with HLH and macrophage activation syndrome. So it's pretty much like a continuum. That's what we think it is. And usually filament HLH is often responsive to IL-6 inhibitor therapy. And we're going to talk about Tocilizumab later on in a couple of slides. But it's usually resistant to corticosteroid treatment. The diagnosis of this is usually hyperferritinemia, especially if your ferritin levels are greater than 10,000 is a good indicator of that. Elevated D dimers, splenomegaly, and cytopenias, especially into hemoptysiac lineages. Here you can see there are two different patients in A and B and C and D. A and B is one patient and C and D is another patient, and you can see the hemophagocytosis in slides B and D for each one of these patients. Okay. We'll pause this. Okay. Sorry, I have no idea why it's doing this. So let's talk about all right. Sorry, I have no idea why it keeps on doing this. Okay, so therapies are usually based on severity of CAR-T, based on severity of the side effects from CAR-T. In the absence of supportive care, IL-6 therapy, Tocilizumab, is usually used. Non-infectious hypoxia is usually respond to IL-6 therapy as well. And remember, if you give steroid therapy, it may impede CAR-T efficacy, like we talked about earlier. And if you overly rapidly taper the steroids, it may provoke relapse of CRES or CRS. So risk of infections in CAR-T. Basically, these patients are at high risk of infections before CAR-T, because these people had, on average, about 4 prior regimens of chemotherapy, and 38% of people who get CAR-T also had prior auto or allo hematopoietic stem cell transplant, and most of these people have pre-existing cytopenias and hypogammaglobulinemias that also are exacerbated during CAR-T therapy. So during CAR-T therapy, they usually get steroids, they get Tocilizumab, and all these increase your risk for infection as well. And usually then the ICU, which is not a good place, as you catch various infections there. And they also have like central lines that also make them prone to getting infections during CAR-T. Even after they get the infusion, they're still not out of the woods yet. Because most of these people, not most, but a lot of these people have prolonged cytopenias that are unresolved even after a month into after therapy. And 53% of people have marked neutropenia as well. So, and a nice chunk of them, about 40%, can have documented infections as well. So they're high risk for infections overall. So I'm so sorry. I have no idea why it's just doing this thing. So infections in CAR-T. Infections occurring with CRS are usually severe and poorly responsive to antimicrobial therapy. CAR-T cells require central manufacturing. So when they're growing the cells in a petri dish in a lab, that is if the lab is not sterile, that could be a source of contamination. 80% of infections are usually within the first 10 days of CAR-T infusion, and these are usually gram-negative bacterial infections, often with antimicrobial resistance patterns. Within the first 30 days of infusion, people often develop bacterial, fungal, or viral infections, and beyond 30 days, it's usually viral infections that predominate. And this could be CMV, BK polyoma virus, which can lead to cystitis. And this is mainly due to the prolonged immunoglobulin deficiency that occurs, and due to the prolonged lymphocytopenia as well. Okay, so active infections should be controlled prior to conditioning on infusion CAR-T cells. That's why we always want to get baseline labs. And if you do have a fever, like what we do at Moffitt, is that we get blood cultures, urine cultures, and chest X-ray. And based on the symptoms, we get respiratory viral screening, CMV, nucleic acid testing, CT scans, lumbar puncture, or brain MRI if they have like neurological issues. So you want to rule out infections. But again, you want to start empiric antimicrobial therapy, and you just may not, even though you have a gut feeling that it might be CRS or CRES, you still want to start antimicrobial therapy because they're a high risk for infection for the reason that we discussed earlier. Quickly, let's talk about Tocilizumab. Pause. Okay. So when you give Tocilizumab, you're at higher risk for reactivation of multiple infections. These include tuberculosis. You're also at risk for increasing risk for reactivation of endemic fungal infections. So you want to, depends where you are in the country, you want to evaluate them for histoplasmosis, toxi, or blasto. In Florida, we may want to evaluate them for strong injury, get a IgG to make sure that they don't have strong injury, and maybe treat if they do. You want to get a history of zoster or HS3 infections. You also want to get a history of if they have history of diverticulitis or gastrointestinal perforation, because I know at when we are rotations, we change our empiric antibiotics based on that. We usually give cefepime, but if they had a history of diverticulitis, we change it to Zilxan. You also want to make sure they don't have open wounds or wound infections, as if you put them on Toci, it could delay wound healing. You want to rule out active infections, especially respiratory infections. And you also want to get a history if they have a history of demyelinating diseases such as Guillain-Barré or chronic inflammatory demyelinating polyneuropathy as well, as these can come back and reactivate. Then the thing about Tocilizumab is that infections usually present infections present after multiple doses of Tocilizumab. Usually in CAR-T therapy, we usually give 1 or 2 doses. So usually it doesn't give you that much risk for infection, but you do have to be aware of that. These patients are also profoundly neutropenic and have been sometimes on steroids as well. And this can lead to invasive sinopulmonary mold infections as well. So be on the lookout for that. So, and that's all I have right now. I could take any questions you guys might have.